Coming up from the American Heart Association is the latest episode of Connect with the CEO. This month, Second Century Impact, Powering the New Health Landscape. It's part 2 of a special 2-part Second Century Impact series. If you missed part 1, you can catch up now or at any time by visiting heart.org/connect now. I'm Greg Donaldson, the association's SVP of Corporate Marketing Communications, and during the next hour, you'll hear from our panel of distinguished experts as we examine new and evolving health landscapes in rural areas, in workplaces, and within digital health. And we'll discuss how to ensure future advances are accessible to everyone during our second century. As a reminder, we encourage you to join the conversation and submit your questions during this live program. You can email them to askAHA@heart.org. We'll answer as many as we can in the time that we have. We'll get to your questions and answers shortly, but first, let's introduce our host for today's program. It is always my pleasure to introduce the American Heart Association's Chief Executive Officer, Nancy Brown. Nancy will guide our thought-provoking discussion on our future impact. So how will we address the unique needs of those living in rural communities? And with so many digital tools now at our disposal, how are we harnessing the power of data and analytics to achieve our personal health goals? And how will workplaces of the future promote overall health and support employee well-being? The thoughtful conversation with global leaders in health and technology will explore these key areas and more as we all strive to empower equitable health for everyone, everywhere in our second century. And for those of you who may not know, since 2008, Nancy has led the American Heart Association and strengthened its position as the preeminent global leader in heart disease and stroke science innovation. And she is poised to boldly lead us into our second century of impact. Under her leadership, as part of a career now spanning 3 decades, the association pursues its mission of serving as a relentless force for a world of longer, healthier lives. The work of today's American Heart Association leverages the power of more than 40 million volunteers, scientists, staff, and donors. Say hello again to Nancy Brown. Hey, Nancy.
Hi, Greg. Good afternoon, and thank you so much to everyone for joining us. I especially want to thank the members of the American Heart Association's Core Vitae Society and our Paul Dudley White Legacy Society. Thank you for your incredible support of our mission. And as Greg said, today is the second episode of our 2-part series devoted to the second century of our mission. In just 2 short years, the AHA will proudly celebrate our 100th anniversary. That's 100 years of improving and saving lives through scientific research, work in local communities, through advocacy for public policies, and so much more. And as we like to say, we are just getting started. With bold hearts, we are building toward our second life-saving century as a relentless force for a world of longer, healthier lives. And if you joined us last month, you'll recall that we discussed the incredible progress that has been made in cardiovascular science and medicine. And we looked ahead to future frontiers of heart and brain research that could change our understanding of human health. We discussed how new approaches like network medicine are being applied to science to better identify, prevent, and treat diseases in the future. We also heard about machine learning, artificial intelligence, and quantum computer technology, and how those assets are evolving to allow researchers to gather and model data to personalize disease treatments and cures. What we have achieved during our first century is extraordinary, but our greatest impact still lies ahead. So today we will be focused on our second century of impact, and we are so proud to be joined by a panel of experts who will help us understand the new and evolving health landscape, including rural, digital health, and workplace health. And together we'll have a conversation about how all of these areas can solve for the gaps that exist for the benefit of all. Just as a reminder, back in 2020, we declared our 2024 impact goal that states that every person deserves the opportunity for a full, healthy life. As champions for health equity by 2024, the American Heart Association will advance cardiovascular health for all, including identifying and removing barriers to health access and quality. This impact goal, of course, intersects with the beginning of our second century, and as we enter the next 100 years committed to advancing health outcomes for all, my panel today will be able to help shed some light on some of the issues, as well as some of the solutions that lie in our grasp to solve these problems. So first, I would like to welcome Dr. Karen Joint-Maddox. Karen is Associate Professor at the Washington University School of Medicine in St. Louis, and she co-directs the Center for Health Economics and Policy at WashU. She is a fellow of the American Heart Association and was a co-author of our Presidential Advisory on Rural Health. Karen, welcome so much, and thank you so much for being here with us today.
Thank you for having me. I'm really looking forward to the discussion.
Thanks, Karen. Our next guest is Dr. Eric Peterson. Eric is the Vice Provost and Senior Associate Dean for Clinical Research, Vice President for Health System Research, and Professor of Medicine right here in Dallas at the UT Southwestern Medical Center. Eric is a longtime volunteer leader for the AHA. He's served in almost every leadership role and currently serves as chair of the Health Tech Advisory Group. Eric, thank you so much for being here with us today.
Nancy, thank you for having me. It's always an honor to work with the Heart Association.
Thanks, Eric. And lastly, joining us today is Chris Wasden, who's the Chief Strategy Officer at Happify Health. Chris is a leading voice on workplace health and brings a wealth of knowledge on business solutions for employee well-being. Chris, thank you so much for being with us today.
Thank you for the invitation. This will be great.
Thank you. Well, our goal is to have a dialogue, but to lay the groundwork of some very important issues that we think about every day at the American Heart Association. I'd like to invite Karen into the conversation to talk about rural health. We know that people who live in rural America have a 40% higher prevalence of heart disease compared with their counterparts in small, metropolitan, and in urban areas. And Karen, I think we know this gap has only increased over the last decade. So we were so honored to have you chair our Presidential Advisory on Rural Health. I think you had Dr. Rob Califf as your co-chair of that paper. Give us a little understanding. What are the issues in rural health? What did we learn from that paper? And what are some of the things we need to be doing to address these disparities?
Sure. So I'll actually start with a little level setting, which is to remind everyone that about 60 million people in the US, or about 20% of the population, live in rural areas. And when we're talking about that, that's an incredibly diverse set of areas across the country, from, the upper East Coast to the sort of middle of the West. And so this is a tricky set of problems and a very diverse set of problems. But there are really, I think, three buckets of major challenges that I know we'll have a lot of conversation about today. The first is that rural areas have barriers to access that are different than in urban ones. So people living in rural areas are less likely to have insurance coverage. And there's a higher rate of closure of rural hospitals. And certainly COVID has pushed even more really to the brink in terms of ensuring access in rural areas. We know that fewer than 10% of physicians are in rural areas, and it's actually much lower than that within specialties, including cardiology. There are also major challenges in quality. So rural hospitals have been historically under-resourced, have been excluded from many quality improvement programs. And so we know that's another area where we have a lot of work to do. And then finally, there are challenges just in the sheer burden of cardiovascular risk factors. So that ranges from our traditional risk factors, so thinking about rates of hypertension and diabetes, but also in social risk factors. So we know poverty and limited educational opportunity impact cardiovascular health. And as I mentioned, about 80% of rural individuals overall are white, but that really belies a deep diversity. And some of the greatest disadvantage we see is in rural communities of color, including communities that are predominantly Black, Hispanic, or Latino, or Native American. And so it's, as I mentioned, it's a diverse problem, it's a broad problem, and it's one that I'm thrilled to see the AHA working on.
Thanks, Karen. You mentioned about hospitals closing, small number of physicians, including specialty care like cardiology in these rural communities. What about the funding models that could help rural hospitals stay afloat? I know the advisory touched a bit on that. Could you give us your perspectives?
Sure. One of the difficulties in rural areas is that you can't really bear risk. You have one very sick patient or sort of one complex event, and it can really be difficult for rural hospitals to survive. And we saw that during COVID. And so there are some creative payment models happening at the state level to try to give rural hospitals sort of a more smooth funding stream. The other thing we worry a lot about is areas that haven't expanded Medicaid. So for rural hospitals to be able to have adequate payments coming in, and we know that they serve a high proportion of patients who are uninsured, underinsured. And in states where Medicaid has been expanded, we've seen fewer rural hospital closures because they were able to have some steady source of revenue to keep the doors open and to build population health and the other sorts of things in a community that you need. So while Medicaid expansion is sort of not sufficient to fix issues in rural health, I think it's increasingly evident from the data that it's really necessary as a starting point to keep rural hospitals financially solvent and to make sure that people in rural communities have stable access to care.
Such an important point, Karen. And it's one of the reasons that as the American Heart Association board made 10 commitments in support of our 2024 goal and our focus on equity, that one of the 10 commitments focuses on a 50-state Medicaid expansion strategy. And that is tough work. It is the work of local AHA volunteers and staff, working state by state to try to help make sure that our patients and our healthcare systems have the funding that they need. And that was one of the really important solutions that the advisory called out. But you had other ideas of things that could be done. Tell us a few of the additional solutions that the advisory called on us to implement.
Sure. And I hope this will loop in with some of the other commenters for today, because I think we need solutions across those three buckets. So if you think about coverage, in addition to insurance coverage, and access through Medicaid expansion, we need investment in workforce and stabilization of the workforce. And we need to use telehealth and telecritical care and other technology-enabled support to make sure that we can take the workforce and other resources that we have and make sure that it extends to wherever people are. Addressing quality will require including rural hospitals and clinics and programs that can help them achieve quality. It will require rural specific metrics that matter to communities and systems level thinking around stroke and STEMI, which can't happen without technology and without the kind of broad thinking that the AHA can help facilitate. And then addressing risk factors, of course, will require community-based interventions. That is true in rural and urban areas, even if the specifics look different. I think the philosophy is the same, which is to say that getting into communities and sort of leveraging the real connectivity within rural communities, along with investment models that can support rural areas more broadly, is where we need to go to try to address some of those risk factors as well.
Thanks, Karen. And this is a great time to bring into the conversation Dr. Eric Peterson. As I mentioned earlier, Eric leads the association's work in health technology. But to me, Eric is much more than that, because I remember 20 years ago, 18 years ago, Eric grabbing me by the collar and saying, Nancy, the world is moving in a new direction, and personal health technology and technology for systems is going to be so important. And Eric, you were right. So here we sit here today, and you hear these problems that Karen has outlined. Give us a bit of your perspective on the landscape of, the world at large as it relates to health technology for systems, for doctors, for patients, but what some of the things the AHA is doing to help address these issues.
Well, Nancy, I remember very fondly when I first met you and you talking to me about scale. How could we take this, everything that we were doing and bring it to the entire nation? And then for all people, as you've now emphasized, that's certainly important goals. I think Karen outlined very clearly that there is sort of a have and have-nots between the urban and rural areas, and they're big problems that the rural communities face. I believe that technology can be, in part, a great connector. As Thomas Friedman wrote just about when you were beginning your tenure, The World is Flat. In that book, he outlines how sort of physical barriers can be flattened by technology, providing equal access to all. So just a few examples of how that might play out. So I would begin with sort of wearable technologies. Incredible improvements have been made in the technology themselves, making these wearable devices, patches, etc., more diverse, durable, versatile, and cheaper. This allows us to bring basically the hospital and telemetry to the home setting. Simple patches can monitor temperature, respiration, heart rate, movement. Combined, we're able to sort of identify when patients may be having problems and intervene before those problems become an event. Another prime example is the smartwatch. Now on our wrist, we have the ability to not only tell the time, but also to monitor our heart and heart rate and heart rhythms. Companies such as Apple and Fitbit have now used these in huge studies to be able to understand the ability to detect diseases such as atrial fibrillation and get those patients earlier diagnosed and ultimately earlier treated, preventing potential strokes. The second set of examples that I would pull out have to do with AI as it relates to image, both interpretation as well as the collection of the data. AI-guided imaging technologies such as an echo allow us to be able to have a healthcare provider get an echo done in even a country away to be able to better understand and diagnose diseases earlier. As an example of this, Andrea Beaton, one of the AHA volunteers and a pediatric cardiologist at Children's Hospital, has used this technology as a part of the SFRM to now look and diagnose a rheumatic heart disease in Uganda. So bringing in this extreme case, the ability to diagnose using high-tech procedures in a country where very limited primary care as well as cardiovascular care exists. So an incredible example of how we can be moving forward using technology. A final example that I'll turn to is mobile apps and mobile app technology. Here, we turn the phone into a data store, a transmitter of information, a processor of that information, and ultimately a feedback and education tool. I think you'll hear a little bit from our final speaker, Chris, as it relates to how we might be using these technologies to better help us each take control and manage our own disease process, and ultimately lead to better treatment monitoring, and then ultimately intervening in our care on a daily basis to improve the quality of care, making patients a partner with us all to result in better health and healthcare. So those would be the three prime examples I would give to you. Open to others.
Yeah, no, those are incredible, Eric. And just thinking back about the rural hospitals and, pioneering work the American Heart Association has done over decades. You were at the table and I was at the table when Get With the Guidelines was created and launched. And Dr. Lee Schwam, a member of our board now, and certainly one of the leaders of our Get With the Guidelines program, when we launched the stroke initiative, where we were closing the gaps in stroke care, state by state, community by community, changing laws so that we could bypass the closest hospital to get to the best hospital for someone who was having an acute stroke. And people like you and Lee were reminding us that, no matter what emergency room you go into, if TPA is going to be administered, and now, of course, the thrombectomies that actually pull a stroke out of your brain as it's happening, that imaging tests are really important. And I remember back, maybe 12, 15 years ago, this idea that a doctor sitting at a large city hospital could use what we now call telemedicine, but, you could use technology to look at an image of a patient in a rural area that may not have a comprehensive stroke center to decide whether or not they were a candidate for TPA. Think of all the lives that saved. And that was really an early, usage of technology. Eric, I'd love you to recollect on those days and all that has happened since that time in the use of that kind of technology to help doctors help each other.
Yeah, telemedicine is sort of this extension of both the monitoring technologies that exist out there, as well as the use of what we're doing today, the ability to talk and communicate across great distances for a variety of reasons. I will take a more up-to-date versions of this now. As COVID-19 set in, none of us could see our patients in our clinics. Even if those lived down the street, they couldn't get in because of the concern for disease transmission. In those settings, we started to use both our phones or alternatively our computers to be able to communicate directly to patients. But that same technology can be used so that I can do a consult anywhere, theoretically, in the country or even across the world. So that ability to either monitor patients in their own settings, talk to patients, do consultations and others is an incredible new gift that's been opened up by technology. I think the latest versions of this are the sort of the Doctors with Heart program that we've actually been talking about with the Heart Association. Similar to where we gave guidance to stroke doctors back in the days of Lee Swam, trying to think about how do we take best practices and try to integrate those into the community. The Doctors with Heart program is an idea of how can we use telemedicine to provide access to high quality cardiology consultation at places that typically don't have access to subspecialty care. That program will potentially allow people in either rural or urban communities where typically cardiologists and cardiovascular specialists are not available to be able to ask questions of a specialist in anywhere in the country and then get back answers and guidance to that care.
Really important. And, you know, through, you mentioned earlier, our SFRN or strategically focused research networks that are ways that we focus on topics important to the American Heart Association and to our mission. Of course, health technology is one of those topics we're studying now through the focused research initiative. And Karen, maybe I'll come back to you for just a moment, because we've talked a little bit about Get with the Guidelines and how that program has helped transform lives of patients who are suffering a stroke. We really think about Get with the Guidelines as an important solution in rural America, along with a new wonderful program of the AHA that we have launched with called HeartCore, thanks to funding through the AmeriCorps program, where we've received a multi-million-dollar public health grant to address a pipeline of public health workers. Tell us your thoughts about these things and your hopes and dreams for what the AHA might be able to accomplish in both to help us achieve the goals you set out in the advisory.
No, I think these are just such phenomenally important programs and really complementary programs. So to sort of take them in turn, the HeartCore program that you mentioned will embed 100 AmeriCorps members through public health in 50 rural communities at federally qualified health centers or rural health centers, which are clinics that serve individuals regardless of their ability to pay and are really focused at providing on-the-ground community-based health. And they'll support people to focus on blood pressure control, nutrition, tobacco cessation, the sort of good, solid public health measures that we know can improve the lives of both individuals and communities, and also develop connections to the rural places that they serve, which will make those folks more likely to want to improve rural health in the future and sort of build the kind of connections that ultimately will let us hopefully continue to translate these gains in the long run. I think it's just a phenomenal program. That then is, I think, related to, in many key ways, the expansion of Get with the Guidelines to rural hospitals through the Rural Health Quality Improvement Accelerator. And in that case, while rural hospitals have certainly benefited from Get with the Guidelines, many of them haven't participated. And it requires a certain infrastructure, certain funding. Some of them may not have felt that some of the quality measures were relevant to them if they didn't actually sort of keep many of their acute MI patients, for example. And so this is rural specific programming being developed to really enroll hospitals in these programs where they can partner, they can learn from each other, they can get support to continue to improve quality in a really challenging era. You know, it was a lot easier to do the same thing at rural and urban hospitals when there was no acute thrombectomy. It's not realistic to have thrombectomy in every hospital. It is realistic to build systems so that every patient can have access to the right technology. And that requires a different level of systemness and connectivity than we really specialize in the US healthcare system. And so I think this effort is really sort of like HeartCore. It's going to not only help in the moment for the people participating, but also to start to build those threads and those networks to really start pulling us together between urban and rural and suburban to get those hospitals and those clinics and those patients, most importantly, really engaged in heart health.
Yeah, it's really exciting, this acceleration of Get With the Guidelines in rural America, and an important aspect of our work that we have been able to implement and launch this year because of the generosity of our donors who allow us to raise money to tackle the most critical health needs. And speaking of critical health needs, Chris, let me bring you into the conversation. You know, it is said, and I don't know that this is the most current number, but about 160 million people who live in this country go to work every day, whether they're now working virtually or working in a physical environment, or, you know, whether they're workers who have never left their work environment because they've been essential workers on the front line, healthcare workers that have provided all of us with basic needs. And we know that all of our workplaces, you know, are going through transition, but we'd love to hear from you. You're an expert in the field. What have you seen in the landscape of workplace health, and what do you think the future might look like?
Yeah, so to bring a couple of these different discussion threads that we've had here around rural health, for example, and technology, one of the big trends right now in employer health is health equity. And if you think about it, there's maybe some surprising things that people that are not in technology like we are don't realize. But depending on your socioeconomic status, you use different technology. Right? Most people that are at the lower socioeconomic level do not use iPhones. Okay, they use Android devices. And the features that they use on Android devices and the type of help or the type of plans they have are very different. And so their willingness to download apps is different. Their willingness to use online services is different because of the cost differentials with regards to different sort of telecommunication plans. Also, their reading levels are different. And so an app or digital service that might be very effective for a college-educated person in an urban area is actually not going to be as effective for someone that is in a rural area that's got less education. And so you actually have to have different language, different activities, different content. You have to take into account other issues with regards to delivery to them and how they would use the product due to their technology differences. And so when we think about health equity, there's a lot of issues that are coming up that I think really haven't been on the radar. And when you think about employers' focus in this area now, as well as health plans, health organizations, and pharmaceutical companies, this is becoming a high priority for them to really be more sensitive to this issue and to address it more effectively than they have in the past.
Yeah, thank you, Chris, for saying that. And that's a wonderful moment for me to make sure that all of our viewers are aware that through our CEO Roundtable, which is a roundtable of about 50 CEOs of some of this country's largest and most influential companies, we created a health equity in the workplace a toolkit and a roadmap to address just these issues. And, you know, we think of people that work in organizations as having access to everything they might need, but, you know, the financial barriers to health continue and persist for people who are employed as well as people who may not be in the workforce. One of the things that we recognize, and we actually just had a meeting of our CEO Roundtable last week, and it's very much on the minds of all CEOs, is this thought about the mental health and well-being of our workforce, especially since the pandemic. Chris, I mentioned earlier, you know, you are a leader of Happify Health, which is Happify Health, and Happify Heart and Mind is an initiative we, the American Heart Association, and Happify Health created together. I'd love you to talk a little bit about this mental health program and how you see it making an impact on some of the challenges in society today.
So I think when you think about mental health, it's easy to kind of carve out as its own thing. But the reality is that most chronic conditions, including all different types of heart disease, are comorbid with mental health disorders to a very high degree. Right, so stress and anxiety drive tension, which has an impact on hypertension. Right, you have depression, which is a large factor with regards to other sort of cardiovascular disease and recovery from those as well. These things are comorbid with cardiometabolic disorders as well. So almost everybody, when you think about cardiometabolic, right, of the conditions that are included, depression is one of those conditions that's part of cardiometabolic disorders. So when we think about it as a company, our roots are in mental health, but we're always looking for this comorbid condition that you need to really deal with your mental health in the context of that. You may have seen an announcement we made yesterday of a new relationship we have with Anthem, focusing on maternal health, because mental health is part of maternal health. And you've got the baby blues, you've got postpartum depression, you have mental health issues associated with getting pregnant, let alone being pregnant, and then after the baby's born. And also we're focused on this with them regarding their insured population, but also their Medicaid population. And this gets into what I talked about earlier with regard to health equity, where the approach that we're going to be using around mental health and maternal health in the context of a Medicaid population is going to be different than how we deal with it in an insured population. And so whenever we think about any disease, right, mental health needs to be part of that discussion, because almost everybody with any disorder is going to have a mental health component of it, where the mental health component can either trigger, so we deal a lot in psoriasis, for example, where anxiety can actually trigger a flare in anxiety. Over 50% of people that have MS, another area we're very active in, have major depressive disorder. And so you've got to deal with depression in the context of MS. Part of our relationship with the American Heart Association is looking at how mental health disorders impact different types of heart disease as well. So that's our approach. We start from mental health, but then we look at it in the context of what other things are going on, because we know this, we kind of forget this, the head and the body are connected.
That's right.
And because they're connected, you can't just treat one without the other.
Yes. Our dear, sadly, no departed friend, Bernard J. Tyson, who is a member of our board, and of course, the CEO of Kaiser Permanente, used to say, you cannot disconnect the head from the body. We need to think of holistic health. And Eric and Karen, I'd love to bring you into this conversation, because I think about, mental health challenges in rural America, technology, Eric, and workplaces. I'd love your perspectives. Karen, could we start with you?
Sure. I think the confluence maybe of a number of different risk factors is really strong in rural areas around mental health. We know they've been very hard hit by the opioid epidemic. We know that mental health is almost inaccessible in many rural areas. And we know that does contribute to both cardiovascular disease and all of its sort of associated comorbidities and outcomes. We also, just to hand off to Eric here, we know that one of the major solutions is going to be using technology to address that. It's not realistic to be able to have physical connections in every rural community. And in fact, there are real issues of confidentiality within rural communities, especially you think about adolescents or young people who the only mental health professional in town might be a friend of their parents. It's, there are some real ways in which leveraging technology around mental health could be a very powerful way, in fact, to get access into rural communities that could ultimately help people promote holistically their health, which is certainly the basis of their future cardiovascular outcomes.
Well, thank you. Yeah, I totally agree. As Bernard Tyson said, we can't separate the body and the brain. I would argue you can't separate the use of technology and the person, that both of those need to be hand in glove. We are learning very well that technology only works if you truly understand behaviors. And while you can, and so working to better use technology and figure out how it works for individuals is becoming, our next challenge. We can come up with lots of bright, shiny toys and lots of applications, but if those applications don't understand the people behind them and the behaviors behind that, we have some challenges in terms of getting to use those successfully. In addition, I'd sort of flip it the other way, which we also need to give time for. We talk about the large problem of mental health as it exists in the public, but we also have to think about it for our own profession. I was struck last week by some statistics looking nationally at how many physicians and healthcare workers in general suffer from burnout. COVID has had a huge impact on this world. As we gear up for more and more technology, more and more inputs coming in, we have to think a lot about the people on the receiving end of that, and how do we make their lives better with technology rather than just filling physicians, nurses, and other healthcare workers with just more inputs and more stresses on their lives.
Yeah. Really important issues, Eric. And I was just about to ask you a question about predicting the future. I'd love your thoughts of how, if we look 5 years ahead, what do we see that experience being for patients and the public, both from consumer health as well as visiting with our doctors? But I'm going to ask you to add that on as it relates to the healthcare workforce, because without the healthcare workforce being strong and vibrant, we really all have to be concerned about our health. So give us a glimpse in the future.
Yeah, on the positive side, I would say that the trends that have been happening are just going to continue to accelerate faster. So we've gone from hospital to clinic, and now we're going from all the way to the home setting. That is here to stay. That's a good thing in general. We can do much more. People are a lot more time outside of our healthcare setting than they are inside. So bringing all sorts of things to people out there and being able to understand how they're doing out there from our perspective is a positive thing. The flip of that, though, is we have to do it in a manner that's not intrusive on either side. From the patient side, we have to make sure that we find ways in which we can bring technology to all in a way that works. Many of our patients early on in the pandemic struggled a lot with using televisits, and many people got left behind in that setting. We had to avoid having a digital divide here. On the other hand, as we've talked about in the Heart Association, healthcare technology can improve equity. So health equity is a concept that we've been thinking about. Are there ways in which we can expand and extend the technology like Doctors with Heart that allow populations who traditionally haven't gotten access to this back to them in their communities where they live? So I think that it will see an acceleration for sure. The question is, how do we accent the positives and limit down on the negatives?
Thank you.
Let me add something to that as well. When we did an analysis the other day to look at the shortages of psychiatrists and therapists in treating mental health. And what we found is that due to the number of people that are graduating with PhDs and with MDs in these disciplines and the current shortage, if you were to continue to produce as many clinicians as we currently do, and assume that the US population and the prevalence and incidence of mental health disorders does not increase over time, it would take 30 years to provide a number of healthcare professionals to meet the current demand.
Wow.
Okay, the reality is that the population will grow. The incidence has increased as well as the prevalence. And so it's unrealistic for us to ever believe that we are going to close the gap in any healthcare discipline, but especially in mental health, by producing more professionals. We're not. Okay. So the only way you close the gap in healthcare around mental health as well as other areas is the same way we close the gap in every other industry, and that's through the application of technology, and especially AI technology. Because the only way to address the needs of people is using technology so that we don't need as many clinicians to deliver the same volume of care, so that we move things towards a more digital orientation with regards to activation, engagement, treatment, follow-up, because it's just physically impossible for us to do it any other way. And the United States, by the way, has less of a shortage than most other parts of the world. Go to China, and the shortage is 10x our shortage as far as therapists and psychiatrists and things like this. So around the world, the application of technology to diagnose and treat patients has got to increase exponentially to address the needs we have.
So Karen and Eric, I'd love your response to that as two people who spend such a good part of your day seeing patients and also helping to create a future state.
I'll take the flip side of that, which is to say that I think it's also really, really important to think about how building connections between people can decrease the need for intervening in a medical sense. So COVID separated people from each other, and that was associated with worsening mental health. And the fix can't only be, I know you're not saying this, but the fix can't only be technology to fix the problem. Part of the fix has to be to prevent the problem in the first place. And I think getting into communities and building communities around health, around keeping people healthy, mental health and physical health, just has to become more part of culturally how we move things forward. And frankly, part of what we see as our roles as clinicians and as policy influencers is to push on that sort of thing. There are amazing initiatives being done in rural areas and urban areas around communities of faith, around communities that come together for another reason, and trying to build on the connectivity using technology or just getting people together, maybe wearing masks when appropriate, but thinking about the ways that we can recognize how important all of that is to our heart health, I think has to be part of the same conversation.
Thanks, Karen. Eric, anything you'd like to add?
Yeah, actually, I'll do my one more prediction for the future.
Excellent.
And that is that the Heart Association will be on the cutting edge of that. And I'm going to choose that for several reasons. AHA was one of the first that really used and looked at where technology might change where we're going, and even brought it into their national meetings. The heart tech and the health tech parts of the AHA scientific sessions were really cutting edge and pioneer. The AHA has maintained its strong belief in evidence and the requirement early on that we have better evidence about what these technologies were doing to help improve quality of care. The AHA has promoted programs that we've talked about in today's session that talk about how do we bring not only just the technology, but actually bring it into people's lives and communities, and then evaluate whether that impact is good, bad, or indifferent. And then finally, the AHA promotes with its collaborators, how do we scale this? Again, getting back to that early issue of taking this to not only single communities, but then taking it out to the nation and then ultimately out to the world.
Yep. Thank you. Love those predictions, Eric. And thank you for the acknowledgement of really groundbreaking work the American Heart Association has been involved in, for a long, long time. We mentioned Get With the Guidelines. Gosh, back in the late 1990s, we created and were implementing a decision support tool at the point of care in hospitals through Get With the Guidelines, when most people didn't even know what decision support tools were. So thank you for that nod. And Greg, I know I'm going to come back to you because I know that we've been receiving many, many questions from our listeners, and I'd love to invite you into the conversation, Greg, to help facilitate some of those questions from our audience.
And our thanks to you, Nancy, along with Eric, Karen, and Chris for the stimulating discussion so far. You're right. We've got hundreds and hundreds of folks listening or viewing across the country. And clearly, the discussion about rural health has touched a nerve. A reminder to those viewing and or listening, you can join the conversation and still send your questions into askAHA@heart.org. And to that point, a lot of conversation around and excitement and energy around expanding access through technology to rural communities. But a fundamental question has come across in several different forms, and that is, how do we deal with, confront connectivity issues in rural areas, whether it's internet access or getting mobile devices into the hands of people that live in rural communities? And we'd love to hear from the panel on that.
Yeah. Karen, maybe you'd like to start because I know we addressed this in our advisory.
Yeah, I think there's the easy version and there's the hard version. I think the easy version, though it will take time and money, is literally the connectivity, is making sure there's broadband access, making sure that there's satellite access, making sure that all of the tech pieces can come together. I actually think the maybe unasked question in that question about how do we then incent people to make the actual connections to use that connectivity is trickier. What's the financial incentive for people to connect out to rural areas as the sort of hub? What are those issues? How can we then leverage that? I think many of us have seen, and I think both of the other commenters alluded to this, that the technology in some ways is the simple part. It's then how do you get people to use it and engage with it and make it sort of get real? So I'm actually optimistic we can solve the connectivity part, meaning literally the wires or whatever people use these days. I think it's the rest of the connectivity that is our next big challenge.
Eric or Chris, anything you'd like to add to that?
Yeah, I'd just like to add that, we in healthcare are going to be helped by every other change that's happening across the nation. If you look at how we shop now, how do we get groceries? How do we do almost everything? It's often through the use of the internet and other sorts of technologies to reach out and bring what we need to us. It makes total sense that healthcare will follow that trend, both for good and then sometimes for challenges. So we have to anticipate those are coming and then think about how do we bring that to all across America.
So what I hear you saying is as everything we do is technology based, there will be a reason for those who, build wireless networks and, put hubs in communities to really focus in rural areas or areas that have not yet had that kind of broadband access, which, is hard to imagine, but it's so very true. And, without every person having access, these great technology tools, will fail to meet the needs of some people. And Chris, I'm sorry, I didn't mean to cut you off.
Yeah, that's fine. The area that is also getting a lot of focus as part of health equity is SDOH, so social determinants of health. And here we see that part of the problem is that things that are fairly inexpensive to provide in the short term and long term, like technology access, are barriers to care and outcomes. And so we're actually better off giving people as a benefit access to technology so that we can then talk to them, work with them, help them. So for example, I've worked in maternal health with Medicaid populations where part of the program is to give them a free cell phone and to give them free cell phone access, because we can help better manage their care if they've got the right technology to communicate with them than if they don't. And if we assume that everybody has to come to the table with a certain type of technology that they can't afford, then that limits our ability to treat and help these patients.
It reminds me of one of the ways that we are helping to enable better health through the use of technology is with the National Hypertension Initiative that the AHA is leading alongside the Office of Minority Health, where we're working with federally qualified health centers and trying to inspire home blood pressure monitoring using home blood pressure monitoring digital tools that can upload readings. And, that is an amazing way to think about improving a very important risk factor like blood pressure and blood pressure management. Greg, let's hear the next question.
Well, and lots of conversation, of course, about the inevitability of certain physical things that need to occur, testing and actually seeing a physical provider and long drives from remote areas. And so I know that contributes to the earlier dialogue about provider capacity and do we have enough providers? Will we have enough providers in rural areas? And how do we get them? But the speakers, of course, have talked at great length about medical providers and capacity there, investing in enhanced and increased and improving technology there. One of our viewers has written in about, I'm curious about the role of investing in a stronger public health systems nationally, and what might that play in the calculus here? And I know, Nancy, you sort of teed up the HeartCore, the AmeriCorps opportunity earlier. I'd be very curious, and I know our listeners would as well, to hear from our panel about that as well.
Yeah, Eric, would you like to start?
Yeah, I'll take this a couple different ways. And if we take it more broadly, your blood pressure comments actually tee it up. Many of these things, do you need to necessarily travel to your doctor's office and then have your doctor adjust your blood pressure? The realities are you can get your blood pressure measured in your home environment, that transmitted to somebody, but that person who makes the changes in your medications could be guided by an algorithm that has already been developed using evidence-based practices. In addition, might be done by somebody who's a pharmacist or alternative. Now with things like monitoring and changing medications for cholesterol as another example, The partners of Brigham and Women's Hospital and Mass General in partnership have tried to use new technologies as a part of the All of Us program, where they're using both algorithms to manage and better change treatment algorithms around lipid management, and then have even trained non-physicians do those changes. So it is possible to potentially use high tech to change around the shortage we have with just only physician-only care in this country.
Karen, anything you'd like to add?
Yeah, I'll be a broken record and go back to the people part of this, which is, I think, a nice connection to the HeartCore piece. And you can have the technology enable that interaction, right? So that you can get a blood pressure reading in the home and it can be transmitted to someone who then can start to make the changes. But if you don't have a trusted person on the other end of that line, it's never actually going to get changed. And you can make all the changes you want, but the medicine isn't going to get filled. If you don't have access to care, the medicine isn't going to get filled because you can't afford it. And so I see these crucial technological pieces as also challenging us to figure out what is the contextual part we have to invest in on the people side. And something like HeartCore, where you're putting real people into a community who can then start to build those technological and electronic connections, I think is where we're really going to start to see a real difference.
So let me kind of bridge these a little bit. So we've been in the past working with obstetricians to look at the change in the practice of medicine there to eliminate half of all in-person visits. So that the woman is doing the blood pressure measurements, the fetal heart measurements, the weight measurements, all at home for half of the visits. And there have been studies that have been done on this. And first of all, the Health and Human Services has been recommending for decades that we cut the number of in-person visits in half. Okay, but physicians don't do it. And there's lots of reasons we could talk about, but anyways, it's not being done, even though it's recommended from a policy perspective. The studies that have been done on this show that the video consultations that the women have when they're doing this stuff at home are actually better and richer than the conversations they have in the office. Because when they come to the office and someone else is doing all these measures, so much of the effort and time in the office is spent on gathering these vital signs that there's not as much time spent actually talking about the woman's interests and needs. And so when the woman's gathering this data at home, she understands the data better, she understands its usefulness better, and she spends more of the video consultation time with the clinician, not talking about the data, but talking about her interests and her needs. In addition to that, she didn't have to get a babysitter. She didn't have to take a day off of work. She didn't have to pay for parking. She didn't have to spend 2 hours driving there and driving back and then waiting in the waiting room and all these sorts of things. So the overall patient experience when surveyed is significantly higher by cutting the number of in-person visits in half. And it just so happens when I tell this story to people that are not as familiar with maternal health, they say, well, the doctors probably don't like it because they're not making as much money. Well, maternal health is capitated. It's a bundled payment. So it doesn't impact the finances. Now, this isn't true, obviously, in other areas that are not paid as a bundled payment, but there should be an alignment with what the patient prefers, what's really improves workflow for the clinician, that doesn't have a negative financial impact as well. And what also the quality and safety information is shown in these studies is that there actually is no deterioration or negative impact on quality or safety for these patients by eliminating half of the in-person visits. So, Mayo Clinic has done studies that show that half of all primary care can be done as virtual visits. When you look at the data now that we've had from the pandemic, almost 80 to 90% of all mental health visits now are still virtual after the pandemic's kind of big effect, although most other healthcare has gone to only 20% or less that are virtual visits. So certain areas like mental health as well as chronic care management are increasingly remaining predominantly virtual even after the pandemic issues have declined.
Thank you, Chris, for those stats. And I know that we follow those very closely at the AHA as well. Greg, we might have time for one last question, and then we will wrap up this conversation with a question I'll ask each panelist. Do we have one last question you'd like to?
Before I give it back to you for summary comments, I think the one question that clearly would be helpful for folks in the context of talking about new technologies is how to evaluate those new technologies, strings, designs to capture health data, BP readings, sleep patterns, heart rate, et cetera. Will these be FDA approved? And how do I figure out which technologies might be ready for me?
Okay, Eric, I'm going to let you singularly answer that question for us.
Yeah, I'm going to be real quick on this one and just say, yes, we need more answers and more study. Just like we need to study new drugs or new devices when they come on market in any setting, we need to find out how these new technologies are actually going to achieve the goals that we outline for them. Just because they're shiny and bright and new does not necessarily mean they are more effective. And understanding both the positive and potential adverse consequences associated with these is pretty key. The Heart Association has stood for evidence forever when it's come to the treatment of patients with cardiovascular disease. We need to continue to keep that same high bar of trying to study what we're doing in real world medicine as it comes to new technologies.
Wonderful. And again, back at the beginning, when we started having discussions about health technology, partnering the science and the evidence with the tools has always been part of our mantra. And as we wrap up this conversation, just very, very briefly, I would love to hear from each of you on what you're most excited about in your respective field as we enter the American Heart Association's second century. Chris, very briefly, what would you say?
Yeah, I'm excited because the pandemic has accelerated our willingness to adopt these things by 10x.
Okay, Karen, what would you say?
I'm excited by the opportunity to partner, getting into communities physically, getting into communities technologically, and really bringing healthcare and heart care to where people are.
Thank you, Eric.
Yeah, I would say it's that these new technologies are incredible, but as we've talked about again and again in this call, it's linking new processes and linking that to the people that are most key. The final issues are the ones that Karen specializes in that are needed. We need to think about policy and payment as they relate to these other two.
Fantastic. Eric, Karen, Chris, thank you for this incredible discussion. And thank you so much to everyone who tuned into our broadcast today. As I said at the beginning, and I'll say it again today, without your support, the American Heart Association could not do the incredible work that we do. As we think ahead to the second century of the American Heart Association, it will be exciting to see how all of the discussion today focused on health equity, rural communities, and technology will really help the AHA continue to make such an incredible impact. Thank you again so much for joining us, and we will look forward to seeing you on our next broadcast.
Thank you.
And
Greg?
our heartfelt thanks once again to you, Nancy, for your leadership, as well as heartfelt thanks to Karen Joy Maddox, Eric Peterson, and Chris Wasden for being with us today. As we leave, we'd like to remind you that June is National CPR and AED Awareness Month. 88% of cardiac arrests occur at home. Put quite simply, the life you save with CPR will most likely be that of someone you love. If performed immediately, CPR can double or even triple a person's chances of survival after suffering sudden cardiac arrest. You can learn the 2 simple steps of hands-only CPR that could save a life at heart.org/CPR. And in just 2 days, on June 10th, we will be celebrating Founders Day, marking the founding of the American Heart Association 98 years ago. As has been said, from its humble beginnings, it has grown into the nation's oldest and largest voluntary organization dedicated to fighting heart disease and stroke. Today, that continued shared focus on CVD and well-being unites our more than 40 million volunteers and our 2,900 employees. We thank you, wherever you are, for being a part of it and for making it all possible. And as we start the countdown to 2024, we will be celebrating all that we've accomplished as well and preparing to boldly step into our second century, as Nancy has said. That's all the time we've got for today. Watch for a complete replay of today's live event. It'll be coming to your inbox, or you can visit heart.org/connect now and mark your calendars for our next broadcast. We'll be telling you about that soon. And as we close out today's broadcast, please watch as a few of our national volunteer officers, as well as our second century campaign chair and past board chair, Jim Postal, share all of their thoughts on why the American Heart Association's second century holds so much promise. Be well, stay safe, and we will see you again soon.
Since 1924, the American Heart Association has saved and improved lives, pioneered scientific discovery, and advocated for healthy public policies in communities across the country. And I am honored to be talking to you today as the association's chair of the Second Century campaign.
The most impressive thing is the advances we've made in saving people's lives. So tonight, people will eat dinner with their families. They will see their children graduate from school. They will see them get married, all because of the work of the American Heart Association. That's what making a difference is.
Pushing the envelope in new innovations and supporting thousands of young investigators who have the best and brightest ideas.
Since I've been involved the last 25 years, it is remarkable how many lives we've been able to save, how we've informed people about the risk associated with them, and how we've impacted everybody's lives in the communities we serve.
I support the American Heart Association because there's really no other organization like it. It's focused on cardiovascular disease, but it's really a public health organization that focuses on science, advocacy, and education.
Each day that I'm involved, I get to see the impact and lives across our country and across, frankly, globally, that we're able to make.
If we could eradicate heart disease and stroke, wouldn't it be something if people never got it? That's kind of how we're focused now, is what can we do to help people keep the health that they're born with? That's my hope for the second century.
This is really passionate for me because I lost a wife to a stroke and I lost a dad to heart disease.
And more recently, our understanding of structural racism as a fundamental cause of cardiovascular disease.
You think about the changes we've seen in society, the research that we have done to help people better understand the risk of heart disease and stroke, how we've changed people's view of women's health in this country, how we've been at the forefront around social determinants of health and how that impacts communities. That's the thing that's most impressive to me. And we have become even more relevant today than we were at the very beginning.
These bold moves have helped transform our nation's health and significantly reduced heart disease and stroke death rates.
It will be incredible to see the second century of impact of the American Heart Association. And what I know for sure is that we will dream big. The future of the American Heart Association will look at the whole person, but it will build on the legacy of what we have accomplished to make sure that we continue this great trajectory of impact every single day.
And so the message of our 2024 strategic impact goal that will lead us into that second century of making sure we are champions for health equity, I think that's going to be the clarion call for our second century.